who is an executive director of Izinta at Wits University. And Prof is an executive director of Wits Izinta at the University of Witwatersrand, Johannesburg, where he received most of his training. His work involves health system research and clinical trials, most recently involving the antiretroviral dolutegravir, tenofovir, alafenamide, cabotegravir, and doravirine. He leads multiple antiretroviral treatment optimization studies and is currently working on new access programs through private pharmacies within South Africa. Patient linkage to care intervention, self-testing projects, as well as mostly recently on the new large-scale primary care delivery platforms that address hypertension, diabetes, obesity, hyperlipidemia, and HIV. Prof has led large PEPFAR-funded HIV programs in South Africa, focusing on men, women, children, young people, truckers, sex workers, LGBTI communities. For over 20 years, Prof has been an advisor to bodies such as the South African government, UNAIDS, and World Health Organization, contributing to international, regional, and national HIV guidelines, and most recently, World Health Organization obesity guidelines. He has an active interest in medical ethics and has been involved in several human rights cases within the Southern African region. He supervises postgraduate students and has over 300 publications, including first author article in major journals. This is a very beautiful profile. Thank you, Prof. Welcome, Prof.
Thanks, everybody. I'm sorry, I wouldn't have made you sit through all that if I'd known it was going to be there.
Awesome.
Can you hear me and can you see my slides?
Yes, we can see your slides, Prof. And I want to tell the audience that I used to just love being a clinician and avoided anything that has to do with advocacy until I met you and I realized that there's no place for just being a clinician. You have to also be an advocate because healthcare has always politics and imbalances. And I don't know which shirt you are wearing today. I don't know. Historically, your shirts always have a key message to share with the world. Thank you very much, Prof.
I'm not wearing any particular T-shirt. It's just the one I was wearing earlier today said TB suspect, which is one of my favorite old T-shirts from the past. So I think, but thanks for the invitation. It's always fun. It's also fun to talk to clinicians, not just doctors, but everyone working in this. And I think for all of you, it's interesting period in our lives, dealing with those. I think many of us, except for the real youngsters here, have grown up with HIV, and we've got a new epidemic here we're going to have to learn from. And I feel very much like I did in 2003, 2004, when we were first got the drugs, the ARVs and stuff, and we didn't know how to use them properly, and we didn't know how to stage properly. We knew how to treat sick people in the hospitals because there were so many of them, but it was a different story, like dealing with these new medicines and how to get people to take them every day. And there were lots of tablets and they had strange side effects, and we had lactic acid doses and everything. So I want you to get your head back to that period for those of you who dealt with that era, because I think we're back there with obesity, and we're also back there with a whole range of the things we grappled with at that stage. And it's quite exciting as a clinician to go back to that period, because to think about how we're going to have to work with our patients and learn at the same time in real time, especially when you're also talking about an epidemic which is affecting so many people around us. And in some ways, obesity is much harder because it brings in issues of food and how people perceive themselves. In the same way that HIV brought in issues of sexuality and stigma, there's tons of stigma around body and shape and all the rest of us. And I don't need to tell this audience how complicated our communities are culturally. So I'm going to talk through this. I'm not going to spend too much time on the HIV stuff, other than to just reflect a little bit on our history and talk about why I found quite weird the transition from HIV and obesity. And I run a specialist obesity clinic, and I'm going to tell you why I ended up there, and hopefully leave some time for questions in the meantime. So let's just get straight into the presentation. Now, I'm not going to spend too much time on the HIV stuff, as I said, but I'm also not going to spend too much time on the obesity drugs. So it sounds like you've got lots of lectures on them. But I want to talk a little bit about my experience with the obesity drugs and having a specialist obesity clinic, a specialist sleep clinic now, and why the HIV stuff actually feels quite easy. The obesity stuff's not easy. And I'd love to hear your own experiences, those of you who have experience. So these are my various disclosures. If you want these slides, the slide deck is 56 megs big, so we have to make a plan. So let's get straight into it. And I really do feel like we're back in 1996, where we're battling with staging systems, with trying to understand things like BMI, because it's not a great staging system with these drugs, which have got lots and lots of side effects. The HIV story, I found this little thing up there on the left-hand side in my notes about 3 years ago. I was cleaning up my old files and things, and you'll recognize, how people had to they didn't have pill boxes. And back in 2003, 2004, we had to have patients had to fill in their stuff on paper. And so those the older ones amongst us will remember these strange things, these tools we used for getting adherence. And there's this endocrinologist, very famous one here at Wits, who came up to me and was lecturing me about how HIV is easy, and that treating diabetes is hard. And it's true, there's nothing about it that I actually came from the diabetes world before I went to HIV. When I transitioned across in about 2000, I actually was a registrar in the diabetes clinics. And in 2025, you essentially you diagnose a patient with HIV, and you give them a tablet and they get better. It's like, go away and get better. You can put a few blood tests. You can do a CD4 count and a creatinine, but you actually give them the tablet and they come back for the result next week. You don't really matter. Don't even worry if the kidneys are a bit messed up and stuff, because those drugs are not going to mess it up in 1 week. It couldn't get easier. And we all know that most of those patients just get better by themselves. The big trick is trying to get them to swallow the tablet. But it's important to remind ourselves what it was like in 2003. We had to do many tests, many tests, even just to confirm HIV. We didn't have the rapids in the old days. We had to, sometimes those blood tests took like weeks to come back. If you were out in the rural areas where I worked initially, sometimes those results got lost and they had to come back. You had to confirm. You had to stage them with the CD4 count. And then we had different CD4 count thresholds for initiating therapy. The D4T tablets we had, you had to take one in the morning, had to take one at night. Initially we had to dose reduce. Remember, in the old days when if you weighed more than 60 kilograms, you got 40 milligrams. If you weighed less, you got 30 milligrams. You had to take 3TC as 2 separate tablets, one in the morning, one at night. If you were a woman of childbearing potential, you got Nevirapine, which you had to dose increase. If you're a man, you got efavirenz. And if you were at the low CD4 count, you got cotrimoxazole. And those of you who are even older will remember the old days when we gave them macrolides if they were at risk of MAC, and fluconazole, if they were at risk of crypto. So when people come and tell me diabetes is hard, you have to go back to 2003 and understand how hard HIV was. It was a hang of a lot harder than diabetes. So, we were able to do hard things. And when the program came along in 2004, it was hard. We did very, very hard things. And with obesity, we probably are going to have to do hard things again. And many of you who are even older will remember, I remember being at school and remember the stigma associated with HIV. I remember Princess Diana meeting somebody, and she didn't wear gloves in 1984 when she went to go and visit an AIDS clinic, and how big a deal of it. And I do sometimes need to get reminded that people with HIV, there's still tons of stigma around them. But obesity might be the last great stigma. I watch people sometimes mocking people who are overweight and thinking, even me, sometimes thought it was okay to make fun of people, or to think it was okay to stigmatize people for this. We also have to remind ourselves how bad HIV was, and it's about to get bad again. I don't know, many of you will have noticed in the news the removal of the PEPFAR funding, and I'm afraid things are grim about that. People think it's okay, we can just integrate the stuff into our normal clinical practice. It's not as simple as that, but there were very brave people who went and fought, including many people within the Department of Health who fought back, and we managed to get ARVs. And We've got one of the best ARV programs in the world with drugs which are world class, and these brave people here, we're at 1,000 deaths a day at one point, and that's come right down. Our new infection rates are right down, our TB rates are right down, thanks to these people. And there were lots of plans and there were lots of things we had to deal with. We had to fight back against our politicians in many cases. Some of those politicians are still there. We had to get the big rollout going. And, we've seen an incredible decrease in the death rates. And interestingly enough, for all the criticism Zuma's had, when he took power, he swept aside a lot of the stuff, the nonsense that was going on in the country. And at the moment, we've got about 6 million South Africans on world-class therapy. And as I said, Trump might mess with that, and that we're going to see in the next few weeks what's going on there. But we actually have an amazing, it's one of the biggest triumphs of the Department of Health is the treatment program. And you can see this in the life expectancy. You can see as HIV took hold across South Africa in the 1990s and 2000s, and then went up in 2010, our life expectancy went up dramatically as the ARVs went into there. That big dip there in 2020, that was COVID. So when people talk to me about COVID not being such a big deal, these weirdos, these anti-vaccine people and stuff come in, COVID was bad. And for those of us who were involved in the hospitals, don't need to be told this. Those big waves took control of our hospitals in a way that was absolutely horrendous. But you can again see the projections are that our life expectancy will steadily go up as long as we can maintain those ARV programs and also get on top of all these chronic diseases. But the drugs were toxic, and I think any of us who dealt with stavudine in particular know it was toxic. But even efavirenz was toxic, and it was fragile. They didn't take your drugs, you got resistance if you didn't take it properly, and they were twice daily. Which any of us who have to take medicines every day as you get older, you start collecting your chronic diseases. You have to start taking your medicines. And when these side effects were stigmatizing, and again, those of you who grew up with stavudine, with D4T, will remember these things. These patients who came in with gynecomastia, with lipoatrophy, where they lost their fat. And those of you who had to manage patients with lactic acidosis was one of the most terrifying things you had to do. Most of those patients died. So this was not a good period during the 2000s as we waited for tenofovir to replace stavudine. And the price of the antiretrovirals went up and up. And my work at that stage was dealing with toxicity, was dealing with advocacy around stuff, was fighting for better drugs, fighting for more money for the HIV program. And then the study that made us famous in my unit was a study called Advance. And this was the movement from efavirenz to dolutegravir. I'm not going to bore you with the details. Those of you not HIV people are not going to be too interested in this stuff. But what we did with Advance is we recruited over 1,000 patients, and we recruited them in Hillbrow. These are not patients, recruited in the private sector or in some rarefied. These were everyday people who we recruited in central Johannesburg. We looked after them in the small little house in Yeoville, in the clinical trials center, and we randomized them to the bottom regimen, which you'll recognize those of you HIV people, which is the old first-line regimen, to the middle of the regimen, which is the first-line regimen, which is what we're using in the state sector and in the private sector. And then the top regimen, which is the one, you get a variant of this in all the rich countries in the world, and which is being used now increasingly in Botswana and Zambia. But don't worry about this. The top two regimens are pretty much the same thing, and they're brilliant regimens. And the regimen and what we did at the time was we started randomizing them in 2015, and in 2019 we reported it. And all the regimens did really well, including the old one. The old one was a little bit more toxic. People fell out of the regimen. And those of you who've used a lot of efavirenz will know they get dizzy, they get rashes. It's easier to break efavirenz. And dolutegravir just did so well. So we talk about this one drug to rule them all. And that's why the national program's done so well with dolutegravir, and rolling it out has been such a pleasure. And those of you who've used a lot of dolutegravir will know, that it's quite difficult. It's incredibly difficult to break, but it's also got very few side effects. But we're not here to talk about ARVs. So this is Tsumiso Sokela. She's the amazing doctor who was on the study with me, and I had a lot to deal with the politics of the study. So I was running around the world trying to fight with Americans and do all this stuff. But Tsumiso is a really good clinician. And while we were doing the study, so you must remember this is before everyone was talking about side effects, she said to me, like, they're gaining weight. In fact, she didn't. She said they're all getting fat. Tsumiso talks straight. And I said to her, it's like they're just turning back into South Africans. And we were both right. But one of the things that happened when we presented this data, so I said all three regimens worked really well, but the one thing we saw was this dramatic rise in weight in everyone on the study. So, and what's been shown throughout the world now is that people with HIV who are treated with modern regimens gain weight, and they gain a lot of weight. And those of you who have a lot of HIV patients in your practice, particularly Black women, will know that that weight goes up and up and up, and it's terrifying to watch. With the one patient with a BMI of over 60 now within the study, and she's done everything. She's changed her diet. She's seen every dietitian. She's done everything. It's really terrifying. And this is what we showed. When we showed this at the big AIDS conference in 2019, with this bottom thing, you can see how much weight some of these patients gain. So I remember I was presenting this patient, and there was a patient in the clinic that week whose BMI went over 40, patients from Alex, and was crying and saying, I've had to change my clothes 3 times because my wardrobe 3 times because I've gained so much weight. I'm doing everything. I'm doing the exercise programs. I'm changing my diet. Nothing's working. I keep gaining weight. And that patient's still in our clinic, and BMI has settled down a little bit, but still well over 40, So the big thing now is that everyone was saying, oh dear, these ARVs that cause the weight gain. Luckily, we work with Sudavi, and she is amazing. She works with Gary Martins at UCT, and they did all this very clever work. I'm a clinician. These people are pharmacists, and they put together all this stuff. And she essentially showed that it wasn't actually the dolutegravir that was causing the weight gain. And in fact, it was efavirenz that's been keeping the weight off in all our patients at the moment. So those of you rushing out to go and change your HIV patients from dolutegravir to efavirenz because they're getting big, do not do that. Efavirenz is a very toxic drug if it's keeping the weight down. And in fact, it's associated with all sorts of the neurological problems and the liver problems, all the other stuff. And Pumla who works incredibly hard and is incredibly smart, has been putting together all sorts of other stuff that she's doing with Samiso and my team to try and show where all of this is. Those UCT people are really, really a huge national asset. So what she's shown is actually, it seems like there's something about being HIV positive and the inflammation that happens there that makes you very prone, that when you switch that inflammation down, you suddenly start gaining weight. And it's interesting because you see that in rheumatological patients, is when you switch off the inflammation, they start gaining weight. You even see it in some cancers, that when you switch and you treat the cancer, people start to gain weight. So somehow there's some sort of feedback loop that's starting to lose. The problem with HIV is there's so many people that are now on ARVs that they're starting to gain weight. And seems something that there's some race and gender stuff there that's going on as well. So you can now turn about and legitimately say, like, Fenta, what were you guys doing all this time? You were sitting around with all these patients, and you didn't notice all this weight gain with dolutegravir and with TAF and all these new drugs. And, when you're just sitting around on your hands, and this is a real lesson. This is why I get angry when people talk about Africans being guinea pigs, because actually the minority of research happens in Africa. It all happens on these white men in North America and Europe on these new drugs. And if you look at the registration studies for new antiretrovirals, they were all done on middle class and actually upper middle class gay white men. And that's why they didn't see it, because the weight gain signal is much lower in that class of people. The people who are really affected by this is Black women. So when you're looking for a side effect, you must look in the side effect in the population that you're going to see. And in fact, when we showed this data to the FDA, they told us that there were more Black women in the advanced study, our study, than in all the registration studies of all the new drugs combined. So that tells you how underrepresented Africans are actually in these studies, and why we should actually be quite angry when drug companies don't do the studies that need to be done in this case. So this just explains why we didn't see this until we started to do the studies. And now it's been replicated across the world in multiple studies. But Samiso was the first person to actually see this. And that's again her and Sissy Kicho, who works in Kenya and who is doing all these studies on these new drugs, these long-acting injectable antiretrovirals that are coming, are going to revolutionize the field in the next couple of years. But we've got all the way from dual therapy to triple therapy to we're looking at weekly tablets to these injectables. So HIV is electrified and it's amazing, but we're dealing with a whole new problem, which is obesity related to being HIV positive. Now, let's switch across to why I'm excited about obesity, because I feel like HIV taught me many, many lessons. One is you know next to nothing until you've used the drugs. And again, for you guys, I feel like we're all at an era where we're grappling with this stuff. I've got an obesity WhatsApp group with a whole lot of clinicians, and we're constantly trading tips and things we learn. And, you really only learn it when you're prescribing it and you're talking to patients and asking them, like you guys are clinicians, you know what it's like. You can instantly tell when somebody hasn't actually been using the stuff themselves. And again, the drugs are coming out and they're changing everything. All the stuff that's been taught to me for 30 years has been overturned by these drugs. And I also don't need to tell you about the consequences of obesity. Now, everything around in that list you've heard of, but it's being increasingly linked to various forms of cancer, to the mood disorders, to stigma around how much you earn in your job. And it's complicated. It's not as simple as saying you're overweight by so many kilograms, hence you're going to have this risk of cancer. It seems to be very different in different communities. It's very different if you're from Thailand, or you're from Indian extraction, or if you're from, Canada, or if you come from northern KwaZulu-Natal. That seems to play out in very, very different ways. The good news is that if you lose a little bit of weight, and not much, like only 5%, you get significant health benefits. And this is important for those of us who, especially in primary care, and especially when we're talking to people, is that we do need to be thinking about weight loss. And you can see here, even for prevention of diabetes, but for treatment of diabetes, for all the bad things that I've listed there, GORD, by the way, is gastroesophageal reflux disease. PCOS is polycystic ovary. All these things are related to obesity. We can tell our people, if you can lose some weight, we can impact on the disease. So we can reverse it. We can get we can lower your insulin. We can get rid of some of your diabetes medicines. We can lower the dose of the hypertension tablets. So we can do something if we can lower that. But this is the bad news, is the lifestyle change stuff. And I need to be careful here, because people interpret this as saying, and you've heard the dietitian earlier talk about this, food, it's becoming increasingly apparent that our food intake is unbelievably important to our health. By itself, it's not going to make you lose weight in the vast majority of people. So just get that. It's very important that we craft that message for our people, is that when you're talking to a patient, your food intake is unbelievably important for your health. It's just not effective for helping you lose weight once you've got weight on board. It can temper your weight gain. It can sometimes help you stay at a normal weight, but it's not going to help you lose weight. So we can get you into 9 different kinds of diet, but to lose weight, we're going to need some help. And the same goes for activity plans. It's really important for you to be active. It's going to bring down your blood pressure. It's going to make you feel better. It's going to impact on your mental health. It's going to do all the good things. But to lose weight, eating properly and simply exercising is not going to do the trick. In fact, the problem is that most people will overshoot when they start exercising. And those of you who've been to the gym know all about what I'm talking about, is that you go to the gym, the first thing that happens is your weight shoots up. And that's because you put on muscle. And you can say, oh, no, but that's good weight. Now, the patient's going to come to you and say, but you told me I would lose weight if I went to the gym. You didn't tell me I'm going to gain weight. Now you're telling me it's good weight. Yeah, and the same goes for diets. I don't know if you've seen this Biggest Loser studies, that when people go on these crash diets, most of them actually overshoot. Most of those people on the Biggest Loser actually end up weighing far more than they actually started with. And this is the thing, is the stuff we promote, sometimes it does our patients actual harm. And we need to be very careful about how we craft these things. And if you go to this study, which amazing article, if you look at those high intensity lifestyle interventions, these are the big study where they almost gave you your own personal trainer to come and sit at home and put a treadmill at home, and you existed on a diet of boiled lettuce and nothing else. You must see these studies and what they actually gave you. It was incredibly intensive. Honestly, we could never afford it, even in the richest countries, let alone on Discovery's Vitality Plan or in the Department of Health clinics. This is, honestly, we call it, my friend and I, Jen, who I published with, we call it the Punisher trials, because it's really a serious punishment. I would never be able to maintain this kind of lifestyle change. But you can see how little lifestyle, how little weight they managed to actually lose in the majority of patients with these incredibly intensive lifestyle interventions. And in fact, when they followed these people out, almost all of them rebounded their weight again. It's not to say that lifestyle interventions are not important for their health, but for weight loss, it's not good enough. Now, if you look at the pharmacotherapy interventions, we're starting to talk differently. And this is where I'm going to get to, and you're going to hear a lot about these things. The other thing is important to understand who's at play here. There are a lot of players, and those of us who are cynics, and I hope you all are about who's trying to make money, everyone's trying to make money. It's not just the pharmaceutical companies. You just need to understand who's trying to make money here. The diet industry is a big multi-billion, the gym industry, the magazine industry, the diet book industry, and every crackpot on the planet is trying to make money. And unfortunately, they're not trying to do it for, some people are doing it from a good place, I admit that, but most of them are not doing it from a good place. They simply try to just get as much, lining their pocket as much as they can. And sometimes the healthcare workers collude. And I see many healthcare workers, simply signing up because they think this is a good idea and that they actually can sell products. They're actually not evidence-based. And we need to understand that when we make people feel ashamed of their bodies, we're playing into a whole mental health area. And there's good data to show that people suffer everything from anorexia to depression to anxiety. And all of you can, I bet you have other family members, if not yourselves, as well as your patient bases, who can actually talk to this. Is that we're making lots of people rich who we shouldn't be playing with. This is not to say that the pharmaceutical companies we should be comfortable with and with what they're trying to promote, but it also does mean that we must understand there are other forces at play here. But I saw lots of chatter earlier about Ozempic, and obviously this is one of the semaglutide, which is the diabetes medicine, is just one. There are so many of these drugs that are about to hit us. There are lots of old oral drugs, which I've been now using for the last few years, which are very, very effective. They're much cheaper. They have their own side effects. All these drugs have their own side effects. Most of them are containable, and especially if you're an astute clinician, you'll be able to use them. You just need to get okay with them. In the same way as we did with those early HIV drugs, you just need to be able to use them. I've put a few of them there on the right-hand side, but there are so many of them on their way. They are damned expensive. Even the oral old ones are really expensive in the private sector. And part of my activism is to try and get the price down. It's unclear which is the best one, and it's unclear what the long-term side effects are going to be. It's important to understand that drugs like semaglutide, Ozempic have actually been here for a long time. They were first used as diabetes drugs. So we do actually, some of them, we do have side effect data that extends almost to 2 decades, which is I'm a side effect guy. So my PhD was on side effects of drugs. There are some drugs we actually do have a substantial side effect profile on, and it's very reassuring so far on what we've got. And some of the old drugs we use for weight loss, we've had for 30, 40 years. So it's important to understand when people say, oh, we don't know what the side effect profile is, we've got a pretty good idea. Some of the newer drugs, obviously less of an idea. And as I said, they are mind-blowingly expensive. So this pyramid I like, because I think it's good for us to get our heads around how we're going to address it and how the pyramid's getting messed up around. And if you look at the pyramid, you can see at the bottom, lifestyle modification. Now, we all need to have our lifestyle. We all need to stop smoking. We all need to get off the chair, stop watching so much television, cut down on the alcohol, eat more fresh fruit and vegetables. We all know what we need to do. Okay, so it doesn't matter whether your BMI is 18 or it's 50, we know what we need to do. And that kind of lifestyle modification, I spent a lot of time in my obesity clinic actually being told, like, these poor patients who've tried everything on the block and they've done heroic things, and yet they haven't managed to lose the weight that they need to go. There are, now we've got dietitians, the audience, we'll talk about specific prescriptive nutritional interventions. I need to learn so much about this stuff, but there are actual meal replacements that can be prescribed by the dietitian. They're quite expensive, but they actually have been shown to work, where you can get some weight loss. So there are alternatives to the actual pharmaceutical interventions that you can use as a bridge before you need to go there. Then as your BMI starts going up and you start hitting that sort of 30 zone, and I'll talk about that in a moment, you start needing pharmacotherapy. There's absolutely no way that you're going to lose substantial amount of weight without starting to need either medical interventions or surgery. And then you start hitting the endoscopic procedures, which are starting to fall away because the surgical procedures are actually so effective. This is a revolution of its own. I attended the lecture last year where, honestly, in the old days when I was a medical student, I was trained around the surgical procedures. They had such a high mortality rate, but they have been totally revolutionized. And just the endoscopic procedures, the numbers of balloon things that they're using at things are incredible. And they're changing every other week practically. So I'm not even going to pretend to understand what to teach you about that. Let the surgeons come and give a lecture about that. So you can see quite a nice gradation there with the the things. But the thing about the pharmacotherapy is that it's become so effective that it's pretty much almost as effective as surgery. So what we've got now is a whole group of interventions that are starting to work. They all work in different ways. Most of them work on the brain. Okay, there are the older drugs. There's some of them that seem to work at the gut. Some of you have used the Lestra, which binds at the gut. It's got so many side effects. I've never used it. There's some old-fashioned physicians who still enjoy it. It's cheap and it's the oldest one around. But it's only associated with 2 or 3% weight loss, while these new drugs, are just so effective that I'm not really sure why one would use it. But you can see, they all work on the craving centers of the brain. I'm going to touch on that in just a moment. Those of you who think learning endocrine pathways are terrible, these neurological pathways are even more terrible. So all these things we forgot when we were in fourth year and thought we'd never have to learn again. I'm afraid you're going to have to relearn them. So this review over there, I've got there on the top, just shows you how many new agents. You can imagine for the drug companies, this is a dream. You can almost write your paycheck because everyone's so desperate for this stuff. And if you look at the price of semaglutide in the private sector, this review article I put out here, it's freely available. It's for those of you who really want to nerd out about how, when I was a medical student, I was taught like fat is where you store energy. And that's like all you needed to know. And there was like different colors of it. And that's about where it stopped. This has completely changed. This is an active endocrine organ that is churning out hormones and doing all sorts of weird and funky stuff with cytokines and inflammation and goodness knows what all, and is far more active than we ever gave it credit for, certainly when I was training. And probably, there's a new paper every week turning it out. And I think that this is a really fun paper for those of you who just want to go and have a look at it. But there are lots of new questions about it. And this paper we published in JAMA just actually came out last month, looking at how we're going to do this and make it sustainable. And the questions we don't know about these new drugs is, do you take them for the rest of your life like you do with hypertension treatment? We know that with obesity, it goes up and up and up. It's almost impossible to arrest. Do we need to take them at the same dose? Can we downscale it? What are the side effects, especially the newer agents? Are people okay with taking these injections? And what on earth are we going to do about the cost? And what we did with this article, which is also freely available, you can just Google it or you can email me for it, is we're looking at, can we decrease the dose? Can we titrate the dose? Can we get away with smaller doses so we just don't have these incredible costs? And maybe with the lower doses, can we get away with less side effects? And part of this, and this is why I'm reassured as a generalist and somebody who's uncomfortable with only using drugs, is that one of the amazing things is when you use, and my experience with this as well, is that when you use the drugs with the lifestyle stuff, they are so much more effective. When you're just going with, you can actually give the drugs without the lifestyle and they actually still work, but they're much more effective if people change their food plans and they start being more active. So this is good news for us because we're not just simply handing out the tablet to try and reverse something. We are actually doing it. And the amazing thing is, because the tablets, I'm going to talk about this, work on the craving area, they reinforce the lifestyle. And this is the way I sell it to my patients. I say, you've been trying these stupid diets and you can't keep them, but you're hungry the whole time. You're finding it so irritating that you can't lose weight. And every time you get on the treadmill, you gain weight. I'm going to give you something that's going to make all of that work better for the first time in your life. And it really works well. And this is why those lower two bars are starting to work much better. And the drugs actually become a motivating factor instead. And it's been so amazing to work. It's like giving ARVs for those first few patients who are skeletons, and they come back a month later, you can barely recognize them because they're put on 20 kilograms. It's exactly the same thing. A lot of my advocacy work comes from HIV. This is a paper we put out on showing that in the same way as HIV treatment, they were charging tens of thousands of rands for a month's course of HIV, and we showed that you can manufacture HIV treatment for a fraction of the cost. We're now showing that you can actually make the anti-obesity agents at a fraction of the cost. And again, in this paper, you can go and pull off the internet. So we're taking all these lessons from HIV and we're using it for the advocacy work so we can get the cost of these drugs down. Part of my problem is I'm not sure which is the best drug yet. So, there's so many of them out there. So is it a Ozempic? Is it tirzepatide? Is it the oral drugs? And this is why people like you are actually really important, because you're starting to use these drugs and play with them. Which are the ones which have got terrible side effects that we don't know about, and which in our local population work better than elsewhere. And I'm finding some drugs actually work better than they're supposed to, and others don't work at all. So this is where it gets freaky. I don't know if you've seen this, but it's clear that these drugs work on the craving sector. And what they've seen is that people they don't just stop eating, they also drink less. They also smoke less, and they start to use it in people who are addicted to cigarettes. They've even started to see that people gamble less. So there's something about craving that is somewhere in the base of that brain. So I come from a family of alcoholics, and I've dealt with alcoholics in my practice. Suddenly having a drug that could actually address alcoholism is a dream. Something that could address opiate addiction, smoking. You guys all know that these are the things we are not good at. Like, and I'm not saying you give them a tablet or injection and they stop drinking all this stuff. That's rare that that's able, but if it could help in a way that is so much more meaningful than the stuff I've been able to do so far, this would be amazing. The problem is the drug company won't give us the drugs to test. We could test in Hillbrow, we could probably test the entire population tomorrow. We could do all the studies in about 10 minutes, but I can't get the drug out of the company. And this is, again, the advocacy work we need to do is to try and get it. But you can see some of the things there, that some of the compulsive behaviors and things. And what's nice about this is my experience certainly with the GLP-1s like Ozempic, is that it doesn't stop the enjoyment of food. It doesn't stop the enjoyment of stuff. It just decreases the compulsiveness of the behavior. And that reassures me, because I think if you took away the enjoyment of food, why would you want to do that? So these are two new epidemics that are coming, and South Africa has to take it seriously, like everyone does, because it has huge economic costs because of the healthcare. And you guys, it's going to come as no surprise, because you know what the consequences of something like diabetes is, in terms of everything from dialysis to going blind to having a front foot. And South Africa is not immune to it. I mean, I don't know what the HIV status is of these people, these famous people, but we all know that we're sitting in another obesity epidemic. And the interesting thing is, the richer you are in South Africa, the more big you get. And that's just got to do with the nature of the changing of our food supply. And we now know that since HIV has gone down as a cause of death, diabetes has become straight up to number one. So number one killer of women now in South Africa, and it's associated with obesity. The number one killer is still TB, and that's because men still are coming into the HIV program very late. But it's number two for men. So all of us are going to need to become obesity, diabetes experts along with our HIV expertise. And there's been lots of data done on how much it's costing the healthcare system. And again, for you, it's going to be no surprise, just having seen it in real time. I think anybody who's a primary healthcare or frontline clinician is going to know this. And again, these papers are freely available if you want to look at them. I think the thing that's exciting for me is I'm learning in an exciting way, like I did at the start of the HIV epidemic, is like the science is evolving so quickly, and things like what is a healthy diet. And what I learned at medical school is like complete nonsense. I think what's evolving now is very clear that the more processed the food is, the worse it is for you. And these additives that are made seem to be driving, and I'm going to come back to a very funny slide in just a moment. And particularly ultra processed food is what seems to be associated with the weight gain. And there's certain populations that are more prone to it than others. And again, I'll come back to the genetic theories around it. But there's something fundamentally that changed our food supply in the 70s and 80s that made food last longer on the shelf, that made it more palatable. It's not just simply that it's fatty and that's more, there's more sugar in it. There's also something else that's been added to it. And one of the things I spend a lot of time with my patients to do is to say, just try to prepare your food yourself. Try and stay with the fresh fruit and vegetables. Stop eating those bars and all those like processed nonsense. Try and steer away with. The problem is it's expensive. And the poorer you are, the easier it is. And actually, the fast food is so cheap. I actually did the back of the cigarette box calculation to say there's like actually one KFC for every 3,000 South Africans. That's one KFC, not all the other chicken like processed things. And you know how cheap that fast food is. So you can see why people actually are going to be steered that way. And I can't see how we're going to fix that unless government gets involved in terms of trying to fix it itself. The other thing is we don't have a good measure of obesity. Now, BMI is what I was taught at medical school, and it's very clear that BMI is not a good measure. We know BMI actually overestimates obesity, clinical obesity in athletes, and we know that it underestimates clinical obesity, particularly people from Asia. And we have no idea in Africans. And there was this thing that just came out in the Lancet. They had this big commission to work out what's a good definition of clinical obesity. And if you're interested, go and look at it, because they're grappling with this. And what they've done is taken BMI, plus they've added on some sort of definition of excess fat, and then they've added on a clinical definition of. So you need all three of these things, a clinical definition of, so if you have sleep apnea, or if you have diabetes or stuff, you add all three of these, you get clinical obesity, and then you need to lose weight. So, but the funny thing about this is I could not find a single African study to contribute to the Lancet. So we try to work out something that kind of and what we're calling is we need a CD4 count for obesity for Africa, so that we can do something, so we can stage it, and then we can measure it if we're doing a good job. So that is locally appropriate, because we know that it's manifesting differently in Africa than it is everywhere else. So this I thought you'd find funny, because as people started to gain weight in the 70s and 80s, their pets did at the same time, which is why I think it has to have something to do with the food supply, is that pet obesity has rocketed. And those of you who have cats and dogs in particular will know this. I've got a very fat cat, and honestly, every time I go to the vet, I get the lecture, and I tell you, it is so humiliating about how they must eat better, and they must exercise and all the rest of the stuff, and I just have to sit there and bear it out. And I think that it's an interesting thing to be thinking about, is what do we need to do to fix our supply? And it's been documented very well. It's exactly the same thing. The other thing is that people come to me and they say, oh, but we mustn't try and medicalize this thing. We must prevent it. And it feels exactly like HIV in the old days. Everyone's like, oh, we mustn't give them ARVs. They must, let's just give them condoms, and that, everybody must die, who must die. And this is a stupid debate. You can't, when somebody's sitting in front of you with obesity, we must treat them. They're not going to lose weight like simply by punishing them. We need to help them, but we also need to fix upstream. And the same way we need to fix HIV upstream, we need to fix all the risk factors. We have to fix prevention, and we need to sort this out. And the reasons for obesity are difficult, as they are for HIV. Like if you go to the lay public and you talk to healthcare workers, they'll say people can't keep their mouths closed. They just will eat and eat and eat. And when you talk to obesity patients, they have tried everything. They are acutely aware of everything that gets into their mouth. And the healthcare workers will blame them. When you talk to obesity researchers and experts, they will tell you it's the environment. They'll tell you that the food is so addictive. It makes heroin look like a cigarette. And that these social determinants, these food deserts. A friend of mine was going through the Eastern Cape recently, and she's a vegan. She could not stay vegan because she could not find fresh fruit and vegetables anywhere in the Eastern Cape, in these rural areas, because they just had processed food. So if you have an environment like that, how are you supposed to eat healthy? So these things, a friend of mine in HIV, she did all these studies. She's the economist, and she used to say this: it's capitalism, stupid. They are tailoring the food supply to make you do this. And she was talking about HIV at this stage, and she was talking about how we never get prevention sorted. We're not going to sort out HIV with just drugs. We have to start dealing with the upstream stuff. And the same thing with HIV. You need to do both. And we can do both things. You don't need to put one against the other thing. And this is Jeff Wing, who taught me how to use the obesity drugs. He's an endocrinologist. He and I learned HIV together when the HIV started in 2000, when we started the clinic at Johannesburg Hospital. And he used to always say about the genes, and he used to say to me, stop with the behavior change. It's never going to work with HIV. And he does the same thing with diabetes and with obesity. He's the one who says the genes are going to sort you out. You have to choose your parents carefully. And that's this kind of stuff where the government's going to have to get involved in regulating some of the food supply stuff. And like I said, the growing consensus is that the food constituents have changed, and we're going to have to fix that if we're going to sort this out. So you can't go to the tuck shop at the school and expect our children to magically lose weight unless we do something about what's in the food supply. And this is a chilling thing, is that a single country in the world has reversed its epidemic. And you'll hear some people saying, oh, Japan's done this and Norway's done that. If you actually look at the actual timelines across decades, all of them, the weight's gone up. Even in places like France, which goes on about French women don't get fat. No, they are. In the last 10 years, they've started to get fat. And it's a real problem. And the problem is there's a lot of denialism. Like in South Africa, there's no plan for dealing with this at the moment. And it's a problem in general. There's lots of talk. Our government's very good at white papers, as we know. And unfortunately, at the moment, there's no resources to address it. And it's not an easy problem to solve. It's not as if America or Canada or anybody else has managed to get this right. As I said, their obesity epidemics are even worse than ours. But it's not as if you can wish this thing away. It's coming, and it's coming big, and the health system's going to get knocked out. And I think one of the things that we have to ask ourselves is, drugs like Ozempic are 6,000 Rand a month. Is it only going to be the CEOs who are going to get it? Because that's what's happening at the moment. Those drugs are so, so expensive. And we have to start building a system like we did with ARVs, where these, even if it's difficult and it's complicated, and we have to deliver obesity care and diabetes care in the same way we did with ARVs. And I think it is going to be difficult to begin with. And people like you are going to have to help, because we have to make some mistakes as we go along. I don't think it's going to be easy. And remember, the ARV program was not easy to begin with. We were giving so many difficult toxic tablets. It was difficult staging and stuff. And it's probably going to be the same with obesity and probably with diabetes on top of it. But we can't keep just pretending we don't have a problem like we did with HIV for so long. And we're lucky because we've got lots of activists trying to help. And these people I work alongside, it's like TAC for food. TAC for food, and people are angry about the food supply, and they want cheap, good food for poor people. And I think that's the stuff we must get behind. You and I can work together to try and fix the system of delivery, but we need to make sure the upstream pressure is there. So I'm almost done. I think this is my last slide. So how are they similar? Well, they're both common, they're both complex, and they're both hugely important. They're both preventable, but they're not going to get better by themselves. They're going to need the government to get stuck in. You can't simply push this onto poor people. Even rich people are battling. And they're both highly dependent on external social factors. And you people are all human nature experts. I don't need to tell you about what those are. I think the thing that scares me is in both cases, Black women are highly vulnerable. And that's scary to me, because you can see it everywhere around us, and we're going to need to take that into account when we start to deal with it. There's also a lot of stigma in play. Every time I turn around, somebody's saying, people must just exercise more, and they must, be careful with their diet. And it's always a skinny person saying that, so it's horrible. And I feel like I've had to retrain myself to stop doing that. The other thing is the new drugs, exactly like HIV, they're transformative, but they are expensive and they're complicated at the moment. And we're going to have to learn how to use these drugs together. And we're going to need the staging systems to come with it. And we're going to have to play with this over the next 20 years, again, like we've done with the last 20 years with HIV. I think the final thing is the delivery system is going to be the Achilles heel. And in all the rich countries, these drugs are available, but almost no one is on them. And in a place like America, 60% of the patients stop their drugs within 3 months, most of the time because they can't afford them, not because of the side effects. The side effects are significant, but because they can't afford the healthcare delivery system. And I worry that this is what we're looking at the moment. We're not paying enough attention to think, how do we do this? How do we craft in the public and the private system a system of delivery of these new wonderful drugs? So honestly, I've seen people lose 40, 50, 60 kilograms of these drugs. Their lives have transformed. Their knee pain goes away, their diabetes clears up, their fatty liver goes away, their blood pressure drops. But we have to be able to do that for everybody, not just for highly motivated people who can afford it. And in the same way we did that with HIV, I think there's a long road that we're going to have to walk to get there. And I'm going to stop there because I talk too much and it's probably late. Thank you very much, everybody. And you can get slides on the vision.
Thank you very much, Francois. This was very, very empowering. I didn't even know anything about what you spoke about. It felt like I needed that, the vets 5 days HIV management course for doctors. I think we did something on obesity.
Yeah, no, I need to go to it. I actually attended the Harvard course last year. Simply because I was feeling so stupid. But the funny thing is, once you start seeing patients, the stuff comes so quickly to you. And because anybody who's been dealt in primary care and seeing patients, you'll be an expert. Somebody once said, you need to see 100 patients and you're good at what you're doing. And I promise you that's the same. I knew within 100 HIV patients, I was good. At 1,000, I was an expert. And I'm rapidly becoming an expert in obesity care. So all I can say to you is many of you are already very good, and I bet you there are many experts in the audience.
Awesome, awesome. Moloko, I don't know your remarks after Prof's presentation. Then we can go through some of the questions from the audience and from ourselves.
Thank you so much, Prof, for such an insightful presentation delivered with a portion of humor. I think a lot of us have been laughing throughout the presentation, and also for reminding us how we have come in terms of managing HIV over the years. And I think this should encourage us as healthcare professionals to get involved in research that focuses on finding solutions to managing various disease conditions that are actually burdening our healthcare system. Thank you, Prof. I'll hand over to the floor for questions.
I'm typing some
Thank
of the
you.
answers in as I'm going for some of the Q&As as I go along, just to try and get as many as possible, but I'll take the live questions at the same time.
All right. I think this word was sorted. Yes, I think you spoke about the issue of the BMI and the staging system. After reading all the articles you have read, Prof, what's your proposal?
So we actually proposing to get a whole lot of HIV positive patients, a whole of hopefully their family members negatives with BMIs over 30, and to look at them over 5 years. We're busy with we're actually submitting the proposal next month, and then to do everything on them, all the stuff in the Lancet paper, including sleep studies, look at their livers for fats, look at their diabetes parameters, and try and work out which is the best predictor for disease, so that we can get, like I said, the CD4 count for obesity. So, and what I think is probably going to be the case is we're going to get a BMI. We'll start with the BMI, let's say 30, because it's sensible. It sounds sensible. And then we're going to add something else on it, and we're going to add something else. And maybe it'll be, I don't know, an HbA1c of 7 or 9 or something. And then we'll add something else, which maybe is going to be a fat measurement of your arm. Or maybe it's going to be a measurement of your sleep apnea index. Or maybe it'll be an expensive fiber scan of your liver. I don't know exactly, because we're going to have to find out. But I saw the question about a person saying my BMI is X and I am healthy. There are patients who've got, there was an amazing presentation by a Canadian. This really skinny black Canadian with dreadlocks, and he gave this politically un-PC presentation at the Harvard course. It was hysterical, honestly. He said, I sometimes have, he doesn't use BMI in his clinic. He runs this big, he's one of the most famous obesity researchers in the world. And I think his BMI must be about 18 or something. But he said, you know what? These patients come to me and I say to them, like, I can help. And the BMI looks like this person's about 25, and I know this person needs to lose some weight. And I need to sort out their blood pressure. And this one woman comes to me and her BMI is 32. And I say, lady, you're black and you're beautiful, and I must leave you alone. And I honestly, I think that's part of the problem, is that people say you're fat and you need to lose weight and you need to do X, Y, Z. And those lifestyle modifications are intrusive, they're expensive, they're a pain in the neck, and they're unnecessary in many people. So if you are BMI X and you are healthy, why are we bothering you? Like, leave you alone. Leave Vitality, leave you alone. Stop making you anxious for nothing. And if you have a BMI of 27 and you need to lose weight, and we need to climb into your diabetes, and we need to make sure your food is the best it can possibly be, and we need to get your blood pressure down, let's bother you rather, and make sure that you're coming back to the clinic as many times as possible. And I think that's where medicine trips up, is we are bothering the wrong people, and we are probably not paying attention to the right people. And that's why I think BMI is a shocking measure. Like, a lot of in the Lancet paper, they'll tell you that the athletes often have BMIs of over 30, and they're pure muscle. They're not people you should be bothering, telling them they must lose weight. So these are the kind of things I think as Africans we need to start grappling with, is who do we need to bring back and pay attention to, and who must we just stop bothering and leave alone, and stop telling them to run around the squatter camps with shoes when their life expectancy is going to come down very quickly, if they do that. So I do sometimes think, we tell our patients, they must cook in olive oil and they must buy 5 different colors strawberries and things like that. those things are expensive for the average South African, and not practical. So I do think we need to start getting our heads around about who we're going to give practical advice to, and what advice we're going to give the people who do need advice, and start tailoring that in a more thoughtful way than simply your BMI is X and you must do Y.
Awesome.
Thank you
Moluka?
for that, Prof. Speaking about the BMI, how likely would you recommend the bioelectrical impedance scales that we use in practice and the skin folds? Because it's true that sometimes you see people who are exercising and they have a lot of muscles and less fat in their body. In that case, the BMI is irrelevant. So how
So,
likely would you recommend the BIA?
so the Lancet recommended BMI plus an anthropometric measurement, and they used body height or just simply sort of doing your waist circumference. And there are a couple of other anthropometric measures, and they didn't mention bioimpedance, but that's one of the measurements which people are talking about using. It just needs to be validated in the local population, and it hasn't been done properly in Africa. So again, none of these things are in and of themselves bad. They just haven't been locally validated. So I couldn't find any studies even using, waist circumference, which should be the simplest thing of all. The funny thing is, when you look at waist circumference, this is where the clinicians will get it immediately. Everyone tells you it's so easy to do until you do it. It is hard, it's intrusive, it's quite uncomfortable to do it. And everyone will tell you how easy it is to do until you look in the clinics and how few people actually do it. It's very easy to weigh somebody. It's very easy to do their height. Doing a weight circumference is actually quite intimate and quite a thing to do. So again, these things, this is where the clinicians will step in. It's like finding an obesity cuff in an in a primary healthcare clinic. It's like the tooth fairy. It doesn't actually exist. So all the hypertension experts will tell you that it has to be done this way until you say, so when was the last time you saw one? It doesn't actually happen that way. When was the last time you sat with your feet flat on the floor for 3 minutes with no one talking to you to do a blood pressure? That's the way it's supposed to be done, and that's not the way it happens. So these rarefied ways of doing things, we just need to make sure that what we use in primary care is practical and is available and then is validated properly. And bioimpedance is one of them. There's the whole range of those anthropometric measures that I'm actually quite keen to test the FibroScan, because even though it's a very expensive instrument, it's so easy to do. You just point at the liver and you go click, 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 and it gives you a really well-validated measure of liver fat. So even though that I can see sitting in a GP practice as something, probably 30% of your patients are obese. Once you've done the initial investment, I can see it sitting in every primary healthcare clinic, in every pharmacy. Once you spent the initial 400,000 Rand, you can probably use it for 10 years. And you can just go click, 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 and have an incredibly powerful measure with your BMI to say, I can leave you alone and you I really need to see next month. So these kind of things we need to start thinking about going into the future. I'm not saying any of these things are the right thing, by the way, because I just don't know.
Yeah. Maybe as a follow-up, Prof, we also see that we have a problem of child obesity. What is used to determine that? Is it the charts, or is it something else?
So we do have an epidemic of child obesity, and in fact, there was a Cape Town group of surgeons, and an orthopedic surgeon and an anesthetist, to contact me independently, saying that they see an epidemic of slipped epiphyses at the femoral head that they need to repair because there's just so many children with obesity. We were actually designing a study for children with adolescents with obesity, and this is going to shock you. We were going to use as our metric, not weight loss, but bullying on the school ground as our endpoint. Like there's a bullying metric, which I'm sure doesn't surprise any of the pediatricians amongst you. But just because there's just so much teasing, I mean, teenagers are just vicious to each other on the school ground, and particularly in the Western Cape, there seems to be a particular adolescent epidemic of obesity. But I think there's a well-described epidemic in South Africa at the moment. And this, again, government has to get involved. We can't have... Next time you go to this, I've just become like the healer, that TAC of food, that made me so conscious of going to the supermarket. Look at where the sweets are. They're all at childhood level. They're not here at my level, because I love chocolates and I buy chocolate whenever I see it. It's all at the childhood level. Up here is where the batteries are and
And it's a
the
trap.
various
Have you seen how it's a trap? Just before you pay, you
aimed at
can't avoid
children.
it. You have to pass there. That.
Yeah. And it's all aimed at children. So mom and dad are going to be, I don't have kids, but like I've got nieces and nephews who whine all the time about buying that stuff. And government's going to have to get involved with the regulation of this stuff. And I don't understand what's so difficult about that. We have to start protecting children from advertising and direct marketing. And the schools also need to start, I saw an article in Nature that said the impact of the amount of sugar that we eat is the same as smoking 20 a day. Now, I watched my nieces and nephews when they're at these school parties, and things, all these children's birthday parties, and they're handing out
Birthdays.
cookies and sugar and things like that. I said, if I went there and started handing out cigarettes, how would the parents react? I honestly think that schools need to stop accepting money from Coca-Cola and the soft drink companies and things like that. I know they need the money, but honestly, the places we should be getting sponsorship from are the sporting areas and things if they're going to be supporting these things, not from people who are promoting poor lifestyle. And I think even within the healthcare, we should be starting to be much more harsh about accepting money from food companies and things. Some of the public health people, they had a big fight at one of the public health conferences where they're handing out free Coke and said, no, they're not allowed to do that anymore. And I think that's where we all need to be going now, is to say, no, we don't accept tobacco money. We shouldn't be accepting stuff which is we shouldn't be promoting as a healthy lifestyle.
Are we too broke to refuse?
Hey, we South African at this point. I see other questions here about which is the better measurement. We actually don't know in our populations whether it's the waist or the waist height. All these metrics, there's some new metrics as well, which are really interesting. And there's some interesting new lab metrics looking at the triglycerides and things like that. So these are all things that I think are big research questions which are going to go out there. This is why it's so exciting to be in the field, is that these are the things we're going to learn over the next little while in our local population. And I think for all of us, just staying on top of the literature and watching it, we're all going to learn from each other. The thing I'm really keen to hear from you guys, though, is the side effects of these new drugs and the old drugs, because that's where I'm learning a lot. Is you only learn when you dish them out. And they have, the one thing I've learned is, particularly with the oral agents, the older agents, is they have so many small side effects, but they're irritating and they come up with the strangest things to you. So I think you're only going to learn that when you start to dish them out.
So before we talk about this intermittent fasting thing, based on the side effects, is there a structured pharmacovigilance program for the use of these drugs in this context on obesity?
No, not. I guess there's as good as they can be. We have quite good side effect profiles on them. They are sadly still in the hands of the drug companies. We're getting more and more data on the ones which are being used extensively, like semaglutide. But like I said, the thing about semaglutide is we use it in diabetes before it started getting used in obesity. So we actually have a good idea of what the side effect profile there. And the same with tirzepatide is that, is that we have a good idea where it's been used. The newer drugs, the drug company went the hold onto these things a great deal. And one of the things I've learned dealing with the HIV drugs is, as I said in my presentation, is you only really find out when you get into the hands of real clinicians and you start using it in research projects which are not being sanitized by the drug companies. I'm fairly convinced, particularly with the older drugs, if you go into those papers I put up there, the good reviews on the older drugs, many of them are 30, 40 years old, and we've got good data on the side effect profile there. So things that, one of the side effects that is not a characteristic of the drugs, it's a class effect of losing weight. And something for you guys to also be thinking about is when, and this is a problem with, you need to be very careful when you start the drugs, is when you lose weight, you lose fat, but you also lose muscle. And that makes sense because you're carrying less fat, so you need less muscle. The problem is when you stop the drugs, you regain the fat very, very quickly. Often in the space of just a few months, you don't regain the muscle nearly as quickly. And it looks like a form of accelerated frailty. So this is one of the things that you need to be very careful with your patients. And what we're trying to work on at the moment is what I do with my patients now, because often my patients, they're all like cycling and they're jogging and they're trail running. they're doing a lot of cardio. They're not doing much weight maintenance. So what you go work with them is to say, when I start the drugs, I want you to be doing a lot of weight training, lifting, and must try and work with the trainers if they can. Many of our patients don't have the money, but they can do weights and things like that. You can give them a basic weight training program, but they need to maintain the upper body, in particular, body mass. And they need to be they need to be just focusing on muscle preservation. I'm trying at the moment to work with some trainers to develop a course for the poorer patients, who are not going to have the means to do this. And then for the middle of the range patients who just need to be quite motivated. And then the people who need to go to trainers. But you'll often get people who are cycling like 5 times a week. Those people need to be told, listen, it's your upper body that actually also needs attention to maintain the muscle mass. So it's a real problem in the States because they can't afford the drugs. They cycle off and on for 3 months, then they go back, and then they're on for another 4 months. So it's a bit, the way I think about it is a bit like those HIV patients in the old days used to start the medicines. They're very high risk for resistance. These patients might be quite at risk for falls and things in the future because they're going to have this disproportionate amount of fats and muscle mass. So when you start these patients, you do need to do quite a lot of counseling beforehand, which is not about the side effects. It's about maintaining yourself. And again, this is where the lifestyle counseling comes in.
Awesome. Moloko, what's your question? I don't know. I see there's a question about fasting there.
Someone is asking if intermittent fasting is effective and if it can be recommended to our patients.
So it's a good question, and they had the big heavyweights on intermittent fasting give a lecture on at the Harvard course, and her perspective was that it's actually the jury's a bit out. There were some studies that suggested that it does reprime your whole insulin systems and make and affect your appetite mechanisms and things. There were other studies which said it just forced you to eat less during other times. I think the consensus was it doesn't do any harm, which is useful to hear. And even if the worst is that disciplines you into eating in a certain way, that's quite good. I tend to, when I talk to my patients, I tend to talk to them in the way and say, listen, it's more important for you to find something that's sustainable for you. Like, if you every now and again eat a chocolate bar, please do not go into like a spiral of despair. And if you pig out at the buffet over Christmas and you eat on Friday night or Sunday night with this family at church or something like that, it's fine. Like, you are going to be absolutely fine. Like, what's more important is on the date, and I'm sure the dietitians will agree, it's like, just find something that's going to, so most of the time you're not eating processed, not rubbish, and you're not eating these protein shakes and the other stuff. Just try and eat stuff that is unprocessed. Try and prepare it yourself. If you're going out to friends, try and fill up on the salad bar and things like that. The dietitians I've spoken to, they've got all these amazing tricks and things. You must listen to the dietitians. They are amazing. They really do help. They like to say, fill your plate with the stuff that's good for you, and like first, and eat that first. And then I've been trying to do that to myself, especially with buffets, because they're like fatal. Those of you who go to conferences like I do, like honestly, you will pig out there. So learn these things and these tricks that you can tell your patients, and how to survive family suppers and things like that. One of the things, for instance,
survive family suppers.
I tell you, families are like no, I tell you, it's a huge problem. We find it's one of the, so I see somebody here talking about internet Ozempic. You must be very careful. There's a lot of, we actually had patients who got very sick using compounded pseudo Ozempic online. Please just warn all your patients not to use that stuff. But one of the things that when you start using anti-obesity medicines, you really need to warn your patients. They must cut their portions right down. There's these Indian families, I tell you, they go home on Friday night and mom just like piles on the food and like, and it's like a terrible thing. The son's going to die of malnutrition, and he's sitting there vomiting in the parking lot because you really have to dramatically drop your portions down. Otherwise your body just reacts. I've had several cases of people who really haven't adapted their food plans and things. Your appetite really dramatically drops. You still enjoy your food, but you really need to eat much smaller portions very, very quickly. So when you start using the drugs, just spend quite a lot of time on the counseling and just reading some of the some of the materials are out there on how to counsel your patients. It's like anything. You just need to use the drugs very carefully in the first few patients, gain some experience, use the ones, don't use too many drugs, use the ones you're familiar with, and then gain experience with them and build it steadily up. But some of them are associated with, most of them are associated with predictable side effects, but they're fiddly. They're not, it's not like ARVs now, where you give them the tablet and go away and get better. You really have to talk to your people and work with the patients. And some of them are sail through it, but most of them actually do need some reassurance and counseling and stuff as you go along. But it's also fun because you get to work with them.
Before Moloko goes through the next question, I wanted to just check clinical guidelines. Is there some draft somewhere? How does
Yes,
it work?
yes. Actually, there's a group of endocrinologists and polydisciplinary group who are putting them through. Angela Murphy's endocrinologist in Alberton, who's putting them together with a whole group of people. So they are looking at this. So it's great. We're working with the HeLa and the civil society group to start putting pressure on various government bodies. We really need these drugs to get into the medical aids. We need them to get to the government systems. They're too expensive at the moment to be handed out willy-nilly. And to be honest, they're not really ready for primary care clinics and doctors yet, because they do require quite a lot. Like you're saying, you went to an HIV course when we first went around. You do need a little bit of care. They're not simple enough yet, but they'll get there. I think and it's not as if they're that difficult, but they're not things you just hand out. You're gonna, like I said, you're gonna have people vomiting in the parking lot. We actually had a patient in ICU a couple of months ago from a doctor who prescribed Ozempic at full dose, and the patient ended up vomiting so much they need dialysis. So you can mess up. And that's not a side effect of the drug. It's just because they went straight to full dose, and you got to slowly go up to the correct dose. So it's not, you need to know what you're doing. It's like anything. And it's a very safe drug if you know what you're doing.
In the right hands, in the trained hands.
Yeah, trained hands. But it's like everything. If you go and give people a wrong dose of an ACE inhibitor, you'll kill them. So it's a very safe drug.
Awesome. We have about 10 minutes or so, colleagues, and then we'll be winding down. It's a 2-hour session. Yes, Moloko, welcome.
Thank you. I like the fact that Prof did mention the issue of sustainability, because most of these diets that our patients are following, it's not that they do not work. They do work, but the issue now is the sustainability. So I always ask patients to ask themselves this question: can I follow this diet forever? And if the question is no, then don't follow that diet, because when you stop following the diet, you regain back the weight, and it becomes a cycle of yo-yo dieting. So which also stresses the importance of tailoring our treatment to each and every patient that we see. Nutrition is not one size fits all. Weight management is not a one size fits all. We need to assess the patient's circumstances to be able to tailor a plan that is going to work for the patient. Thank you. So our next question is, I think it's
great advice.
Thank you, Prof. It seems the drug regulates the release of dopamine, that is from Zippo.
So that terrible neural pathway that I was telling you about, there are all sorts of theories around where it's clear that it's not simply the neural pathway. There's a whole range of other things that seem to be at play. It's also quite clear that there's a very nice review in the Lancet on the GLP-1s. As I said, one of the things I always say is, after the age of 50, learning endocrine pathways is a human rights abuse, as far as I'm concerned. Like, I've had to come back years later and find all these hormones which were never discussed or described when I was a medical student training for my fellowship exam. Honestly, and then you have these bits of the brain that never really made sense to me in the first place. Now I have to go and understand. So if you really want to scare yourself, go and look at where these things play. And I think the stuff I find more interesting is to think about where craving comes from. So hearing that gambling comes from the same place as appetite regulation, as opiate addiction, is really interesting to think about for our patients, rather than worrying about dopamine and things like that. So the GLP-1s, where they came from, the history of where they came from, there's really interesting stuff online that you can go and read about it, which challenges a lot of the stuff I certainly understood about where appetite regulation is. There's actually a full review on appetite in the NEGM just a few weeks ago. So everyone's getting on this boat and everyone's interested, and because it's something we all can relate to, which is food, it's worth actually going and reading about it. Yeah, shopaholic. I must tell you,
Yes,
just to tell you, Refill, where one of my patients came to me 4 weeks ago. She said to me, doctor, I came off my Ozempic, but she's trying to decrease the dose because she can't afford it. And she's managing to keep the weight off. And she said, I'm just so hungry and I can't stop shopping. So it really is the thing. It's all about craving.
Yeah, before we go to the next question, Prof, I wanted to ask, can you explain why in the same household you would have a sort of overnourished person, obese, and there's also a very underweight person, which usually it's a child. But I also understand there's a concept where you are obese, but at the micronutrient level, you are malnourished. Can you try and just give us a sense of what's happening there?
Look, I think you've got dietitians in your group who are probably more qualified than me to work on that. And again, you've got genes and you've got food and you've got tapeworms and you've got, different kinds of gut and things all in the same household. So I really do think you probably need a better qualified person than me. But you're completely right. You can go into the same household and see. You can also see family members where one's a stick and one is like a pear. And you want to say, are you sure you've had your genes checked that you're from the same family? And it's, but the reality is that's it. Like I remember, like I was skinny, and then I did my fellowship, and I hadn't stepped on scales for 10 years because I just never really worried about my weight. And then suddenly I gained like 20 kilograms. I didn't even notice because I was so busy and studying, and specialization was difficult. So everything was just an absolute catastrophe. And then it's because I lived on chocolate and Coke because I was doing so many night shifts. And, some things, even your genes can't protect you from, I think, age and too much Coke.
I think
So
to
any
add on
innovation
that,
to choose your sorry, Buluk, I just want to because Prof, I wrote down, you see, where you were saying, I think there was a quote from someone, choose your parents wisely. So I wanted to check if there's any innovation.
Yeah, I think one of us, like, we want to choose parents who are billionaires and skinny.
Okay, Buluko, sorry, sure.
just to add on what Prof was saying, and also choosing our parents wisely, we need to remember that our health circumstances are also influenced by like what our parents ate, like preconception health of your mom will contribute to your health. If the mother had diabetes during pregnancies, we end up having bigger babies who are also at risk of having chronic diseases of lifestyle. So there's a lot of factors. If the mother was breastfeeding, I'm sure we all know as healthcare professionals that babies who are breastfed are now at a lower risk of getting all these chronic diseases of lifestyle. And then adding genetics to it and lifestyle factors is just a lot of factors that contribute.
No, you're completely right. I mean, many of us will remember from medical school that thing called the Barker's hypothesis, where if mom is undernourished during pregnancy, her baby is primed for obesity. It's almost as if the genes gets turned on to be, to get to sort of say, there's a area of famine around me and I must put on as much weight as possible. So, making sure maternal health is optimized in every possible way should be an absolute government priority. So I think, which is only a good thing anyway, but it just does talk to the fact that this thing is really complicated, and that and it's also why it's so cruel to make fun of people who are overweight. It's like these things are absolutely so often out of their control. It's not to say that there's nothing they can do about things, because I also think, we mustn't preach that people have no volition and that there's no control, because that also leads to a cycle of despair that I think is not useful. But I also think, there's a level of cruelty that even I've been part of. I think back over the years, that is not okay, and that we just mustn't be part of that. We need to say, when somebody's in front of you asking for help them. It's not the time to lecture them on how they're stupid or have no self-control. And I think we all must stop that. And when I watch people on the internet and in public and our politicians mock each other, for their weight or for being lazy and stuff like that. Like, we just must include with that. It's like right up there with teasing people about their race or their sexuality or their height. Like, it's just it's what they are, and like we must just not be part of that.
Powerful.
And also, I think Mr. Magoza did mention in his presentation that also mental health also contributes. So stressing again the importance of that professional collaboration.
Yeah, and certainly it's strongly associated with depression and anxiety, and you can understand why, and I think you also need to be quite careful in the initial present. So the people come to me want to lose weight. So it's, to start the conversation around weight loss is fine. I think, but if you're in general practice and somebody comes to you and you're worried about their weight, it's quite important to be quite careful about how you initiate the discussion, because maybe that person's not interested in losing weight, or they don't even think they're overweight. And I think it's very important to not introduce a whole area of anxiety into them. Well, actually, they might be quite, like I said, BMI is a rubbish metric of staging of obesity. And if you might think they look a little bit overweight and you want to have a big discussion with them, and now suddenly you're making them worry, and they're actually completely healthy, and they might be healthier than you. I mean, one of my favorite patients at the Johannesburg hospital used to say, these nurses come and shout at me about my weight, and they're all fat, doctor. And it's like, you do need to sometimes take a step back and look at how this entire thing must look from the side of the patients.